Hello everyone. Today we will discuss chapter 318 from Harrison, which is about nephrolithiasis, kidney stones. So it is one of the commonest topic and one of the commonest condition with which many working adults will be suffering. So we have to know it thoroughly and we will follow a order which will be helpful whenever we are practicing clinically. So chapter 318 about nephrolithiasis. As I said, it is one of the commonest condition. Common, severely painful condition. And it is mentioned in the Harrison that it is also a costly condition, because it will affect mainly working individuals, in turn reflecting financial burden. Next we will mention about the types of stones, types of kidney stones. Here the commonest type will be calcium oxalate stones. So these will account for about 75% of the total renal stones. Then comes calcium phosphate stones, accounting for about 15%. After that, in order we can consider uric acid stones, about 8%. Then struvite, cystine stones, which are about 1% prevalent. And some stones are mainly composed of medications, that is, some medications will lead to stone formation with the composition of the medication itself. So just to mention such few medications, we can remember 3 A's. Here A for acyclovir, then atazanavir, and one more is, this is triamterene. So these medications themselves can lead to stone formation. So these are few types of kidney stones. Now we will see what are the risk factors for a person to develop kidney stones. So we will see the risk factors. If the individual is having some malabsorption disorders, like Crohn's disease, they are at risk of developing kidney stones. Also obesity or overweight, diabetes, hyperparathyroidism. And when it comes to diet, there are some food products which will increase the risk of stone formation, and there are few which can reduce stone formation risk. So those which will increase stone formation risk are mainly consumption of animal protein, sucrose and fructose rich food products, high sodium, that is salt intake, then increased oxalates, which is commonly found in spinach, potatoes, etc. So these are the ones which will increase the chances of kidney stone formation. There are some foods which will actually help in decreasing the risk of stone formation. For example, potassium rich foods, then alkali containing food products, mainly vegetables and fruits. Then we can consider dietary calcium and phytates, again found in vegetables. So these will reduce the chances of kidney stone formation. Coffee, tea, beer, wine, and adequate hydration. Even orange juice are considered as helpful in relation to nephrolithiasis. So this is about diet. Similarly, some urinary factors will also influence kidney stone formation risk, which we will see now. Urinary factors to list out mainly the volume. So if the urine output is less than 1 liter per day, risk of kidney stone formation will be double risk. So ideally, we have to expect more than 2 liters of urine output per day. It is helpful. Then urinary calcium. Whenever there is increased calcium absorption from GIT, this happens when we take calcium in the form of supplements, but not dietary calcium, like supplemental. So this is a risk factor. Then we can consider increased urinary oxalate levels. This happens when there is insufficient calcium in the diet. So if there is not sufficient calcium, the oxalate will be excreted into the urine. So urinary oxalate levels will rise, leading to risk of calcium oxalate stones. Also, increased levels of uric acid in the urine will lead to uric acid stone formation, mainly because of animal protein excessive consumption. Here one more factor is low levels of urinary citrate is a risk factor for stone formation, because this citrate is a inhibitor of stone formation. So this point is very important. Whenever there is lesser urinary citrate levels, it will be a risk factor for stone formation. Again, this lesser level of citrate is seen when there is increased animal protein consumption, because this animal protein will cause more reabsorption of citrate in kidneys, leading to lesser quantity in the urine. So these are some factors related to urine. Then urinary pH will also determine some of the stone formation. So urinary pH. We told that commonest form of stones are calcium oxalate, but these are not affected by urine pH, won't affect in any ways. Whereas for uric acid stones, the risk of uric acid stone formation will be more if urinary pH is less than 5.5. Whereas the reverse, if urinary pH is more than 6.5, risk of calcium phosphate stones will be more. Similarly, struvite stones, risk will be increased. These stones, struvite stones, are also called as triple phosphate or infection stones, because some microbes, when they infect urinary tract, will lead to production of urease, for example Proteus bacteria. This will lead to increase in the pH. So as pH increases more than 6.5, there will be increased risk of phosphate stones. It may be calcium phosphate or struvite, that is triple phosphate stones. So why this is so important? Because in this situation, usually we will give alkali syrups such as citralca. So this will again lead to further rise in the pH, aggravating stone formation. So in kidney stones where phosphate is the major reason, we should avoid this alkali serum. This is about the effect of urine pH. And one more risk factor is family history. Family history. So whenever there is positive family history, the risk of stone formation will be 2 times. So these are some risk factors for stone formation. Just to sum up, some comorbidities like diabetes, obesity or overweight, hyperparathyroidism or malabsorption are the risk factor for stone formation. Similarly, some dietary factors and urinary factors, urine pH and family history. So these are some factors which will affect stone formation. Now we will see the pathophysiology of nephrolithiasis. So in pathophysiology, now we got the risk factors. How does it start and how it will lead to manifestation? Mainly because of the 2 things. One is supersaturation of the urine. Supersaturation of urine and decreased levels of citrate in the urine. Decreased citrate in urine, which we mentioned that a natural inhibitor of stone formation. Inhibitor of stone formation. So this imbalance will lead to calcium oxalate or phosphate deposition at loop of Henle. So this is the initiation site. So from there it will trickle down towards renal papilla, eroding the papillary epithelium. Then they will get deposited at the tip of these papillae, which is also called as, so this is the tip of papillae. Here they will get accumulated. This is called as Randall's plaque. This will lead to the manifestations of clinical features. So this is the pathophysiology. Initiation site will be loop of Henle and one more important site is Randall's plaque. So we know that clinical features of nephrolithiasis are mainly 2 things. Clinical features. Individuals will present with renal colic and there might be hematuria. So this will start as flank pain. Mainly those who are working at hot climates and many young individuals who don't have easy access to washrooms. If they start developing flank pain with hematuria, with or without hematuria, we have to consider nephrolithiasis. So for this flank pain, we have to keep some differentials also in mind. Mainly acute cholecystitis, acute appendicitis, and acute diverticulitis. These are some closest differentials for nephrolithiasis. Then how to go ahead with the investigations, how to evaluate the case.